Welcome to Clinical Minute. Nawal is a 30-year-old woman presenting for a contraceptive consult. Based on the information from the standard intake form, you know that Nawal's sex is female and her last pap test from 2 years ago was negative. She presented for STI screening approximately 1 year ago, and her last normal menstrual period was 14 days ago. When you enter the room, you see a woman of color wearing a hijab. After scanning the intake form, you assume that the medical assistant meant to write preconception counseling instead of contraceptive counseling. You wonder if Nawal's husband will be entering the room shortly. You say, "I see you are here for preconception counseling. Would you like to wait for your husband before we begin?" Nawal looks confused. She says, "Husband? No, I am not married." You follow up by asking, "Your fiancé then? I see that you're here to discuss planning a family. Since you are 30 years old, we don't have to worry about your age and the risk of genetic abnormalities. There is an increased risk for gestational diabetes, however, based on your weight. This can impact your health and the health of your baby. We can go over all of this in more detail, and you can tell your fiancé that we provide the best in maternity care." Now visibly hurt and uncomfortable, Nawal says, "I'm here to learn about options for preventing pregnancy." You apologize and attempt to move on by asking about her previous experiences with birth control. Nawal responds briefly, "The pill." You ask her how satisfied she was with that method, and she says it was fine. You offer to renew her prescription or to provide information on other options, and Nawal says, "Just the prescription, please." You write the prescription and ask if she has any additional questions or concerns she would like to discuss today, and she quickly says no. Nawal leaves with a prescription shortly thereafter. What went wrong in this clinic visit? Assumptions made early in Nawal's visit caused the patient-provider relationship to suffer. Her visit ended abruptly without a comprehensive contraceptive review or a discussion of sexually transmitted infection, or STI, testing and prevention, which may lead to worse health outcomes for Nawal. Provider bias played a large role in many of the missteps that occurred during this client interaction. There are two types of provider bias: explicit bias and implicit bias. Explicit bias is a bias that a person is aware of and believes is correct in some manner. An implicit bias is a bias that is unintentional and unconscious, but is activated quickly and unknowingly by situational factors. One way to evaluate your own implicit biases is to take the implicit bias tests that Harvard University has developed. These are short tests that evaluate the implicit biases that you have toward a variety of races, genders, religions, and identities. The implicit bias tests can be found at https://implicit.harvard.edu/implicit. Provider assumptions and biases about sex, gender, nationality, religion, and culture can create a hostile, unsafe, and unwelcoming environment for clients, resulting in discrimination and stigmatization. As happened with Nawal, provider bias can undermine client-provider trust, which may ultimately decrease receptiveness to contraceptive counseling. Moreover, one negative experience involving bias has been shown to delay future healthcare access and contraceptive use. Negative interactions can foster shame, secrecy, and silence. Furthermore, clients may choose to omit accurate information about sex, gender, sexual orientation, or sexual behavior. Based on this information, what could you have done differently? Simple updates to the client intake form can signal to patients that you are a gender and sexuality inclusive provider, which may help many clients feel more comfortable when having conversations with you. These updates should include sex, gender identity, sexual orientation, and current sexual partner or partners. In the case of Nawal, the sex she was assigned at birth is female. Her gender identity, which is marked as woman, aligns with her sex, making her cisgender. Another question on the intake form regarding sexual orientation allows Nawal to indicate that she identifies as queer, which is a term used by some people who are lesbian, gay, bisexual, or transgender. A question about her current partner or partners allows her to note that her primary partner is a woman and her new partner is a man. Nawal also indicates that her religion is Islam. However, it is important to keep in mind that Islam includes a wide range of beliefs and customs, and providers should be aware of their biases surrounding certain cultures and religions to ensure that they are listening to each individual patient's values and preferences. In this encounter with Nawal using an updated intake form, you are better prepared to discuss contraception with Nawal, as you have a greater understanding of her social and clinical history. You will be able to prioritize Nawal's values and preferences by minimizing the impact of bias. You walk into Nawal's room and see a woman of color wearing a hijab. You saw on her intake form that Nawal's religion is Islam. What are some considerations that may be important for providers of Muslim patients? You know from your research that modesty is not synonymous with weakness or submission. In Islam, the general concept of modesty is important and is often more emphasized by women. According to the Pew Research Center, roughly 1/3 of Muslim women in the United States choose to wear the hijab, a headscarf that covers their hair. A smaller proportion of Muslim women may choose to wear an abaya, which covers the whole body, or a niqab, which also covers the face. Women may choose to wear the hijab for many reasons, including religious piety, communal or social norms, protection, or as an identity marker. According to a review published in Obstetrics and Gynecology written by Dr. Sarah Shahawi, for many, modest dress is a symbol of independence and self-worth, a statement to others and for themselves that their bodies are, first and foremost, their own and not to be objectified. Regardless of why women choose to wear or choose not to wear modest clothing, providers should not make assumptions about their preferences and values, nor should they pass judgment on clients' decisions. In Nawal's case, her hijab does not hinder a physical exam. However, you know that if her modest clothing did make a physical exam difficult, it would be your responsibility to ensure that Nawal had access to a same-sex provider if requested. In some cases, the presence of a same-sex staff member may be an acceptable solution for clients. How do you proceed with providing contraceptive counseling for Nawal? Based on your updated intake form, you know that Nawal is presenting for contraceptive counseling to prevent unintended pregnancy and STIs. To begin the contraceptive consult, you ask an open-ended question. What have you and your partners done in the past to avoid STIs and undesired pregnancy? Nawal tells you that she has used condoms for most interactions with her male partner. She said that in college she used birth control pills, but that was almost 10 years ago. What is your next question for Nawal? When you ask Nawal how satisfied she was with those methods, she says that there have been a few times when they did not have condoms on hand, so they had unprotected sex. She says that she has also struggled to take the pill regularly in the past, which resulted in an unintended pregnancy and an abortion in her junior year of college. She tells you that, in the future, she wants to ensure that she is protected from STIs and pregnancy without having to remember to take a pill or buy condoms. Now that you have elicited Nawal's values and preferences, you rephrase the things that she's told you to ensure that you have a comprehensive picture. You say, "From what I am hearing, it sounds like you and your primary partner want to make sure you are having safe experiences with each other and your other partners. For you, that includes having sex with men while remaining confident that you are protected from STIs and unplanned pregnancies. Is that correct?" Nawal says that this is correct. You say, "Let's begin by discussing pregnancy prevention. Then we can talk more about STI prevention. Since it sounds like you are prioritizing effectiveness and convenience in your birth control, I am going to tell you about some of the long-acting forms of birth control. Then we can discuss other types of birth control if you're interested." Since Nawal expressed interest in highly effective birth control, you say to Nawal, "Here is a chart that explains the effectiveness of contraceptive options. At the top, you can see that intrauterine devices, or IUDs, and the implant are two types of birth control that are basically as effective as surgical sterilization, but are reversible. And they are also great options for someone who prioritizes convenience." You display samples of IUDs and the implant so that Nawal can see and touch the different options. You tell Nawal, "I'll start with the implant and IUD, but let me know if you have questions about other forms of birth control as well. I'm happy to discuss how other types of birth control will work for you." You say that both implants and IUDs prevent roughly 99% of pregnancies, and the main differences are the presence of hormones and the way that they are inserted into the body. You mentioned that there are hormonal and non-hormonal versions of the IUD, but the implant is only hormonal. You then show Nawal the various IUDs and explain that IUDs are inserted through the cervix and sit inside the uterus. You explain that this requires a pelvic examination and a short procedure that can be uncomfortable. You then show Nawal the implant and explain that the arm is numbed before the implant is inserted into the arm. You note that bruising can occur, but the procedure itself is usually painless. You ask Nawal if she has any questions so far. Nawal says, "No, I don't have any questions, but I think I'm already leaning toward the implant because I'd like to avoid the pelvic examination if possible." You affirm Nawal's preference and continue to explain that the implant is approved for up to 4 years, but it can be removed at any time. You explain that fertility returns immediately upon removal should Nawal decide that she's ready to become pregnant. You then discuss the common adverse events with her. You say, one of the most common issues with the implant is irregular bleeding. This usually occurs in the first 6 months after insertion, but it can occasionally last for a year, and for some women, it never goes away. If you experience this side effect, there are a few things that we can do to manage the bleeding, including an anti-inflammatory drug like ibuprofen, or a course of birth control pills that could help to regulate your cycle. You assure Nawal that she can request to have the implant removed at any time should she find any of the side effects unacceptable. You make sure to mention that there may be a co-pay for early removal, since you know that this can pose a financial barrier and feel coercive to clients who choose to discontinue LARC use before the package insert recommends removal. You ask Nawal if she has any questions. Nawal asks if you can insert the implant that day, so you consult the CDC guidelines on how to be reasonably sure that a patient is not pregnant. You note that Nawal does not fulfill any of the criteria to rule out pregnancy, since she has not consistently used a form of contraception during every sexual encounter, and it has been more than 7 days since her last period. You ask Nawal to schedule the insertion for one of the first 5 days of her next period. You counsel Nawal on the importance of using a barrier method for pregnancy prevention until the implant is inserted, and for STI protection even after the implant is in place, since the implant does not protect against STIs. You say to Nawal, "You mentioned that you use condoms most of the time. On the occasions that you don't use condoms, is there a specific reason?" Nawal says that most of the time she has forgotten to buy them or bring them with her. She also noted that it can get expensive on a graduate student stipend to regularly buy condoms. You say to Nawal, "I can understand how that might make things difficult, and an interesting alternative might be internal condoms. Many people call these female condoms because they were originally designed for women. However, they can also be used internally by women and men for receptive anal sex with the inner ring removed. Since these are an FDA-approved form of birth control, I can provide you with a prescription, and the cost should be covered by your insurance. When used correctly, internal condoms have been shown to provide equal STI protection compared with external condoms. Is this something that you'd be interested in?" Nawal is excited and says, "I had no idea. That would be very helpful. Thank you." Nawal says that she thinks the reduced cost would help her use them more reliably for STI protection. You go ahead and demonstrate how to insert the internal condom using a demonstration model. What are the next steps for Nawal? You encourage Nawal to consider STI screening, since it has been more than 6 months since her last testing and she has started seeing a new partner. Nawal agrees to receive screening and says she will pick up the internal condom you prescribed on her way home. Nawal returns to the clinic 2 weeks later to get her implant. After insertion, you remind Nawal that she can call anytime with questions or to schedule a removal. You tell her to expect irregular bleeding for the first few months and to call if she finds it unacceptable or bothersome. Nawal thanks you for your help throughout this process, noting that she is relieved that she can concentrate on her studies without letting concerns about pregnancy interfere with her relationships.